As I mentioned here, we're going to go with documenting the fact that people are ovulating, and then we also want to do general health screening. Because thyroid dysfunction can cause women to not ovulate well, we actually measure TSHs, and we're pretty aggressive with this. So people with subclinical hypothyroidism, we go ahead and treat, and especially also if the level is between 2.5 micro international units per ml to about 4, we will also check anti-thyroid antibodies, because it's been shown that those people will develop thyroid disease further in the future, and we'll treat that subclinical hypothyroidism if they have positive anti-thyroid antibodies. So unfortunately, there's going to be some women that don't ovulate. And so what we're going to do is, for those people that we want to have that have chronic anovulation, we'll go ahead and check their thyroid. We'll check other reasons why they might not ovulate. We'll check their thyroid, we'll check whether or not they have hyperprolactinemia, and then we'll see whether or not they have a positive withdrawal to progestins, because then we know they're estrogen prime. If we have those parameters, if you're normal thyroid, you're euprolactinemic, and you withdraw to a progestin challenge, we functionally call those women have a history of chronic anovulation, and we call them women that have polycystic ovarian syndrome. We don't do any other more elaborate testing. I think for the generalist, that's about enough that you need to have to make that diagnosis of chronic anovulation. So, as I mentioned, this could be a diagnosis of exclusion, and all the other secondary testing we might do more in a research mode or let's say at a tertiary center. But I think for the generalist, if you can make that diagnosis, that's enough that we would then say that yes, that woman has enough irregularity in her cycle that she has a history of chronic anovulation. So to go ahead and reverse that, we'll go ahead then and see if we can kind of give her that bolus of FSH that usually occurs during 2 or 3 days early in the menstrual cycle that she's not making. Because women that are chronically anovulatory are just kind of idling in place. Their LH level is always greater than their FSH level. So we want to give a transient rise in FSH. And we do that by 2 medications. We've classically always used clomiphene citrate, but the medication that we've been using in the last 15 years is letrozole. And the reason that we've gone to letrozole, because there's side effects with clomiphene citrate. Because it's an anti-estrogen, it can bind to the estrogen receptors and decrease cervical mucus and thicken the endometrial and thin the endometrial lining. So this causes other factors that we don't really want to see in women that are trying to conceive. One of the side effects of letrozole, because it drops your estrogen level, what it does, it blocks the aromatase enzyme that converts androstenedione to estrone or testosterone to estradiol. And when levels of estrogen levels are low, it simulates what is the normal endocrine environment around cycle days 2, 3, or 4 of your menstrual cycle. So it kind of sets you at that beginning point of the menstrual cycle, and then allows the body then to think, oh, I'm in a low estrogen state, I'm going to make more FSH because I'm going to bring up an egg for this month. And that's what allows you then to stimulate a cohort of eggs for that month. But because the drop of your estrogen level is so dramatic, some women will have some hot flashes when they're on their letrozole course for those 5 days. So if we've gone ahead then and gotten this woman to ovulate, but we want to then maybe shorten her time to pregnancy, and she also may have, let's say, a low level of, let's say, a borderline level of low sperm count, we'll go ahead and consider doing intrauterine insemination. Intrauterine insemination is done typically with the patient in a pelvic exam situation, where we'll take a concentrated amount of sperm and place that within the uterine cavity. And we'll insert that sperm with this plastic catheter. And then as we start to think about this, and we want to go ahead then and see, are there any ways that we can go ahead then and actually try to increase the number of chances of you ovulating? We'll go ahead and we'll think about using spontaneous, instead of using just the spontaneous menstrual cycle, we'll go ahead and try to see if we can increase FSH and do what we call a controlled ovarian hyperstimulation. We primarily do this though now in the course of in vitro fertilization. We do this by administering gonadotropins. Remember, gonadotropins come from the base of your brain, from the pituitary gland. If we can augment that with medication, we can augment it with FSH or LH, we can increase the number of eggs you make. This is actually where Ferring over here has a medication called Menopur, which is a combination of FSH and LH-like hormone to actually stimulate your ovary. And so what we have here is, this is an ultrasound view of a woman that has been stimulated with gonadotropins. And each of these black fluid-filled areas here is a potential egg. We've injected this woman with self-injection with FSH and LH. We're going to increase her number of eggs from 1 to maybe anywhere from 5 to 7 or 10 or 12 for in vitro fertilization. And correspondingly, we're going to increase her estradiol level from 250 picograms per mil for one dominant follicle up to maybe 10-fold if there are 10 follicles, 2,500 to maybe 15 follicles here, and get to a level of almost 4,000 picograms per mil. So in the course of doing in vitro fertilization, we'll do transvaginal ultrasound scanning. We'll attach a needle to this probe, and then we'll go up through the vagina. When the patient's awake under conscious sedation, we'll go in, we'll vacuum the eggs out of her ovary for the process of in vitro fertilization. And then normally, once we have those eggs, we take them to the laboratory, and we're going to go ahead and fertilize them by incubating sperm and eggs together. Usually we place anywhere from 25,000 to 100,000 sperm in a little drop of fluid with the oocytes, anywhere from 1 to 5. And the concept here is, my couples always talk about, well, are we still going to get natural selection? Well, we'll get some natural selection, but it's not like the situation when you're having intercourse where you're ejaculating sperm into the vagina that have to go through the cervix, into the uterus, up through the fallopian tube, and there's a loss, there's just this winnowing effect of number of eggs, number of sperm that make it up to the egg. Here we're putting anywhere from 25 to 100,000 sperm around the egg, and then they will go ahead and then they will fertilize the egg. But the problem there is that sometimes, even with that type of increased number of sperm around the egg, we don't get good fertilization. So we have to think about something like, for men with very low sperm counts, like a process called Intracytoplasmic Sperm Injection, or ICSI. And this is where we'll directly inject the sperm directly into the egg. So what I have here is a video of an actual sperm injection process. Let me just give you a little bit of a explanation of what we have here. This is a holding pipette of a mature oocyte. This is a polar body that's being released, and this is the sperm injection needle that we're going to go and insert into the egg. And right here is the sperm. So let's go ahead and I'll show you. This is the actual ICSI process. So you see here the sperm is being moved back and forth. They're moving the sperm to the tip of the needle. And they're going to inject the needle right into the egg, puncture it, and then they're going to bring up some of the fluid that's within the oocyte into the needle to make sure that it's actually punctured. Think of this as like a pencil going into the like a surface of a balloon, and that you can indent it. But if you don't puncture it, you actually can't inject the sperm into the egg. You can't inject the sperm directly into the egg. And so this is where the sperm was injected, and that's the whole process. That's the process of intracytoplasmic sperm injection. Once the egg is fertilized, then it's called a zygote, and then it starts to divide. It's a two-cell, this is in the normal pelvic organs where the egg is then fertilized. This becomes a zygote, turns into a 2-cell, a 4-cell, 6-cell, and by the time it comes into the uterus, it goes from an 8 to a 10 to a 20 to a 40 to a 100-cell embryo. And then this 100-cell embryo then becomes what we call a blastocyst. I have here a picture of a time-lapse picture of a single cell being fertilized, and now a 2-cell embryo. This is the actual embryo. This is time-lapse photography of the embryo going from a 2-cell to a hatching blastocyst. You can see here there's multiple cells there. This is like a 20-cell embryo. Now we're forming a blastocyst here, cavity. And then it's going to hatch out of its shell called the zona pellucida, and this is a hatching blastocyst. And this is what is actually implanting in the wall of the uterus.